Uh, is the colleague from Glasgow, Hyatham Kubba, and will speak about nasal obstruction in neonate. But I think it's not live, but it's from video. Are you ready? Okay. Thank you.
Hi, I'm Hyatham Kubba. I'm an ear, nose and throat surgeon from the Children's Hospital in Glasgow, and I'm going to be talking about nasal obstruction in neonates. I have no financial disclosures to make. Nasal obstruction in a neonate is one of those things that you may not enjoy being called about if you are an adult rhinology specialist, but I assure you it is very straightforward. It presents as a problem because children are obligate nasal breathers for their first few months of life, which means that they can't choose to breathe through their mouths. They have to breathe through their noses. If their noses are obstructed, they will become hypoxic and distressed. And this may show itself with the classical cyclical hypoxia, where the child becomes hypoxic and distressed. They then open their mouths and cry, at which point they breathe through their mouths, so they then become pink again, and they're happy and they settle down. They then stop breathing when they close their mouths, and they become hypoxic again. Milder cases, which are only partial, may show themselves as stertor with nasal discharge. The clinical assessment is straightforward. You can just hold a cold surface, such as a lax tongue depressor, underneath the nose and look for airflow. Just look for misting. That will tell you if air is flowing. A simple otoscope examination of the nose will tell you if there is a mass in the nose causing obstruction, and you can attempt to pass a nasogastric tube. You can see if it will pass the nostril at the piriform aperture, or if it will go into the nose but then won't pass through the back because of the posterior choanal. So you get a lot of information from these simple things, and you may supplement that with an awake nasal endoscopy with a flexible scope. The most important thing, though, is to make a clinical assessment of the severity of the problem and looking at the baby, and are they struggling to breathe? Are they recessing? Are they using accessory muscles? Are they very noisy, obviously obstructed, and even hypoxic? And this determines the speed with which you need to manage the problem. So the things that we're going to consider in this talk then, the differential diagnosis really is craniofacial anomalies affecting the middle of the face, which are very obvious when you walk in the room. We're going to talk about piriform aperture stenosis, which is a narrowing at the nostril, which is congenital. We're going to talk about choanal atresia, which is a bony obstruction, a complete obstruction at the back of the nose, again, congenital. We're going to talk about nasal masses, which should be visible when you look in the nose. And then finally, we're going to talk about neonatal rhinitis, which is by far the most common of all of these problems, but it's the diagnosis you make when you've ruled out all of these other obvious abnormalities. So the first thing is to talk about congenital nasal anomalies that are obvious when you walk in the room. Now, these things are all very rare. Complete absence of the nose is self-explanatory, and these children will usually require a tracheostomy. Various syndromes will affect the maxilla, and the most common are the syndromic craniosynostoses, which is Cruzon, Apert, and Pfeiffer. The midface is very small and underdeveloped, the eyes are exposed, and there is an associated craniosynostosis. And the problem here is that the maxilla is very small and it sits very posterior, so the nasopharynx is very narrow. And some of these children will require tracheostomy, some may be okay with a nasopharyngeal airway, some will manage with simple conservative measures. But their management is complex as part of a craniofacial team, and most non-specialists will not be asked to look after them. And the same is true for those with complex facial clefting syndromes, such as this one, where you've got a duplication of the nasal septum causing narrowing of the nose. So these are rare, they're complex, and they will be managed by specialists and specialist centres. Piriform aperture stenosis, though, is surprisingly common, and the diagnosis is made when you see that the nostril is just a hard bony slit, a very narrow slit, and it's very difficult to get an endoscope or a nasogastric tube into the nostril at the front. And you see on CT that the width of the aperture from side to side is 11 millimeters or less. And you see these large bony spikes on the front here, which are the cause of the problem. And from here to here is 11 millimeters or less. So you need a CT to really confirm your diagnosis. And also because there are associated anomalies with piriform aperture stenosis, and 1 in 5 of our series in Glasgow also has a unilateral choanal atresia, which is important to know. You see the narrowing at the front of the nose on the 3D reconstruction, but what you also see is the single central incisor tooth. Now, this is the child at 6 months of age when the teeth have erupted, but you see the tooth bud in the gum. If you just rub the gum, you can see that there is a central tooth bud. It's also visible on the CT. So this confirms your diagnosis. This is present in about half the cases. So it is quite a common finding, but it makes the diagnosis for you. Other anomalies that are associated, brain anomalies, particularly holoprosencephaly, which has a variable prognosis. So we need an MRI brain as a neonate. We had cardiac abnormalities in 3 out of 10 of our children. Echocardiography is certainly worthwhile, but the most important by far is the pituitary abnormalities. You must be aware that the pituitary may be abnormal, and this can affect growth. So they need hormonal testing in the neonatal period, but they also need to be followed up with growth charts for at least 1 year. And that's based on our series here in Glasgow. Half of our series managed just with simple medications, humidification, suction, management of associated reflux, and some topical decongestants. But half required surgery, which is very straightforward. It's a sublabial incision, lift up the soft tissues, drill the edge of the piriform aperture. I usually put stents in for a week. Not everybody does, but for a few days it can be helpful. So that's piriform aperture stenosis. So you may or may not have been familiar with that, but you will all be familiar with choanal atresia. I'm sure you are. And here you have the classical CT appearance with a mixed membranous bony atresia across the back of the nose here. And you can see the difference. The piriform aperture is very large, and that's normal. You see the difference with the previous case. So the problem here is the choana. This is bilateral, and you make the diagnosis initially because you can't pass a nasogastric tube through the back of the nose. You can confirm that with a fiber optic endoscopy. I think CT is essential for diagnosis and for planning the surgery. Half the cases are bilateral and half are unilateral. Classically, the bilateral ones present at birth. The unilateral ones classically present later with unilateral nasal discharge, but many of them do struggle and present at or near birth. And I think if they're struggling, then they do need to be repaired because they are at risk of becoming hypoxic, and it can be a clinical problem. I don't think that unilateral ones should be ignored if you find them in a neonate. And we have to be aware that 35% of them will have charge syndrome, so more so the bilateral ones, but even some of the unilateral ones. So I think they all need to be screened for cardiac anomalies primarily, and that needs to be done before you consider surgical repair. The ultrasound of the renal tract, their hearing test, their ophthalmology examination, these things can wait, but they all need to be done at some point, but the echo is really important before anesthesia. This is how I do them. I do them in the tonsil position. So I sit at the head of the patient with a small shoulder roll and the neck extended with a cleft palate gag in place and the soft palate pulled forward with a little stitch through the base of the uvula. Then put a 120-degree endoscope in the mouth and look behind the palate. And this is the view you get from the nasopharynx, looking forward with the eustachian tubes on either side, the palate at the bottom and the adenoid at the top. And it's then straightforward to pass instruments through the nose, and you see them coming towards you here. We perforate the atresia, which is always a mixture of membranous and bony. It's always mixed. And we can put in a cannulated burr, the cannulated 4mm diamond paste burr, which we can use to then drill out the choana. And we can take some backbiting forceps and take off the back of the nasal septum as well. I usually put in nasal stents because these children are obligate nasal breathers. The choana often narrows and requires dilatation a number of times. It's nice to just get them through that obligate nasal breather the first few weeks by putting in some nasal stents. There are different ways of putting in stents, but these are cut endotracheal tubes with a small spacer to protect the columella. And at the back of the nose, there is a suture passing through them, which just holds the tubes nicely in place. And you see this is what it looks like in the nasopharynx as the suture pulls the tubes together, and then the whole thing is pulled into place in the choana and sits very nicely. So that's choanal atresia. And the important thing to move on to next is nasal masses. These should be obvious when you examine the nose. And the thing that we really are very concerned to diagnose early is the meningoencephalocele, and this is what it looks like here in the left nostril of this newborn baby. So it's a smooth pink mass, which may expand on crying with a classical sign. So that's a meningoencephalocele. Now, you may also get an intranasal glioma, which is a congenital hamartoma containing neural tissue. So it's a meningoencephalocele which has become detached from the brain, and the skull base is intact, leaving a residue of brain tissue within the nose. So a congenital intranasal glioma is in the differential diagnosis. We will also get babies presenting with lacrimal cysts causing nasal obstruction, and they require to be marsupialized into the nose. And hemangiomas are quite common in the nose, usually not present at birth, but they'll present over the first few days or weeks of life like this